Hi, it's Tom here from Running Physio. Today I wanted to talk to you about Plantaris involvement in Achilles tendinopathy because this can be a bit of a stumbling block for people with Achilles tendon pain and it's very much under-recognized. So in this video I'm going to talk about three signs that you can spot in clinic that would suggest that Plantaris is involved in Achilles tendinopathy. I'm also going to talk a little bit about how you can modify treatment if you suspect Plantaris involvement and also surgical options as well. As ever, we've put a link to our free webinars that you can check out. We've got a great series on iliotibial band syndrome, lateral hip pain, lower back pain, and of course Achilles tendinopathy. So do check those out as well. So let's start with a little bit of background around Plantaris and its involvement in Achilles tendinopathy, because that helps us make sense of some of the other factors. First of all, if we think of the anatomy, the plantaris tendon runs just medial to the Achilles tendon. So they're closely related in terms of their anatomy. And it's thought that that plantaris tendon can compress the Achilles around about the site that we might expect to see a mid-portion Achilles tendinopathy. So it's thought to be a little bit like a compressive tendinopathy, like insertional tendinopathies might be. For example, insertional Achilles tendinopathy at the heel, where we think the tendon's being compressed against the calcaneum. So it can present then a little bit like an insertional tendinopathy. Now, there are scans and investigations that can help us identify this. Ultrasound and color Doppler can be useful. We can sometimes see evidence of a thickened plantaris tendon, which might suggest it's involved in Achilles tendinopathy. And more recently, UTC has been used quite nicely in Maskia Tool's work. So UTC, ultrasound tissue characterization. Now, this is good because it can actually identify areas of the tendon where we might actually start to see some tendon disintegration, where perhaps some of the tendon tissue is replaced by more disorganized fibrillar matrix. And this is shown with these red regions that show up then on UTC. And we can see that in the image, in an image on a UTC, where you'll see these red regions towards the medial side of the tendon, as shown in Maskia Tool's work, indicating the involvement perhaps of plantaris tendon in Achilles tendinopathy. Now, in terms of the pathology, there's been some really nice work from Van Sterkenberg, particularly in their PhD thesis that they produced, indicating some of these pathological changes that you might expect to see with plantaris involvement. So as I said, you can have a thickening of that plantaris tendon. You can start to see adhesions develop between the paratendon and the Achilles tendon itself. And then you can start to see ingrowth of nerve and blood vessels as well. And some of the pathology work sort of seems to show that the tendon almost seems to be almost attached to the Achilles itself, perhaps then leading to irritation of the Achilles and symptoms during loading. So there's a little bit of background in terms of the anatomy, the pathology, the kind of location of plantaris. So next up we think, well, what are these three key signs that plantaris is actually involved in Achilles tendinopathy? Well, the first one would be medial Achilles pain. You can see that that's where the plantaris sits. It's just medial to the tendon. And we can see with those UTC studies, it tends to be perhaps more medial changes we would expect. So if a patient's presenting to you with Achilles tendinopathy, it's a mid-portion problem, and the pain is more medial, that could be one of our key signs. So that's the first thing to consider. The second is that it behaves like an insertional tendinopathy in that the pain is often worse when the tendon is loaded into dorsiflexion. So if this patient is complaining of an increase in medial tendon pain when loading into dorsiflexion, that should make us suspicious that perhaps plantaris can be involved. So first factor, medial pain. Second factor, aggravated when loaded into dorsiflexion, like a calf raise off the edge of a step or calf stretches. And the third factor is when a patient's not responding well to a tendon loading program. In some studies, I believe in one of Muscular Tools studies, 16 of the 18 participants in that study had failed to respond well to a tendon loading program. So if you have those three factors, medial pain, aggravated by loading into dorsiflexion, hasn't responded particularly well to a tendon loading program, and you've given it a good period of time, you've given it at least 3 months of progressive rehab, we might really be considering Plantaris involvement. So the next step is to get appropriate imaging. So we could look at getting ultrasound. If you've got access to it, looking at something like UTC may be an even better option. We have had cases recently where some of these changes in the tendon have been missed on MRI. So it's important to pick the right investigation and perhaps team up with a consultant for an ankle specialist so that they can, you can work closely with them to decide the next steps. If you do think it's a plantaris that's involved, we do need to modify the rehab. Now, particularly if it's irritated by loading into dorsiflexion, we need to move out of that, at least initially. So we might look at doing our calf raises on the flat, or seated calf raises on the flat as well. So we're not going into dorsiflexion ranges. You could do similar things with things like leg press calf raises if you want to. So it's avoiding that dorsiflexion range. You may choose to focus on more isometric exercises if they're better tolerated. And typically with this group, I try and create some change within the tendon by progressing the load rather than pushing too much into range until the symptoms have settled. Now, then there's a bit of a debate, as there is around insertional tendinopathy in general, as to whether you push them into provocative ranges. Now, my stance on this would be that yes, if it's tolerated, if there's not a lasting increase in pain, particularly in the next day, we might start to gradually work into dorsiflexion range, particularly if their function demands it. So if you're working with a hill runner, they're going to be loading that Achilles into deep dorsiflexion positions running uphill. So it's difficult to avoid that altogether, but we need to choose the right stage of the rehab to do it. So it might be that we wait until it's less irritable and we start to just gradually introduce some range and be guided in terms of progression by their symptom response. Now, as we said, in some of the studies, quite a high percentage of people will not respond particularly well to a loading program with this particular condition. So then we need to think about the next steps. And this is where it can be really good to team up with an orthopedic surgeon, a foot and ankle specialist, to see what options they can offer beyond physiotherapy. So we've had some clinics offering local injections around the plantaris and Achilles tendon to see if that might help to settle things down and improve the situation. So sticking with less invasive procedures initially. If that isn't working and getting the results that you want, though, you can go to surgery to remove the plantaris tendon. Now, it's thought to be a little bit like the appendix in that it's a very small muscle. It doesn't contribute a great deal to function. So you should be able to remove it and its tendon without it having a negative effect. So it's a relatively low risk procedure with some encouraging results in the literature. Some studies in athletes, around 90% were satisfied post-surgery, with around 94% returning to sport. So it is one where I think if you're not getting the improvements you want, if you have those key signs of medial Achilles pain, aggravated by dorsiflexion, if you're really not getting the progress, then I think it is something where we would team up with a consultant, have it tested out, see if that plantaris is involved. And if it is, think about modifying your rehab and think about whether you want to go on to those next steps, including surgery to remove it. Okay, so whistle-stop tour then of plantaris and its potential involvement in Achilles tendinopathy. Just to sum up those three key signs again for you. Number 1, medial Achilles pain. Number 2, aggravated by loading into dorsiflexion. And number 3, not responding particularly well to a tendon loading program. That would make you suspect plantaris involvement. And then you need to modify your rehab by reducing dorsiflexion and think about the next steps in terms of potentially surgical removal if it's really not responding to what you're doing. Okay, do check out those webinars I've put a link to for you. They're all free. You can sign up to those and enjoy them at your own leisure. And I'll look forward to speaking to you again very soon. Thanks for listening. Bye for now.